ahead of schedule. Program committee, I think it's an important topic that we spend a lot of time as spine surgeons thinking about the impact of what we do, both with surgery and without surgery, to our elderly patients. We have some great speakers in our lineup. Corinna Zygourakis, who's going to talk about frailty and the impact on timing and overall treatment of elderly cervical fractures. Thank you.
Okay, wonderful. Well, thank you very much, Dr. Bisson, Dr. Moore, and the CSRS Scientific Planning Committee for inviting me to speak today. Here are my disclosures. And I know we're a big group, but I'll get started with a few cases and ask you guys to vote on what you would do. I realize there's incomplete information and I'm selecting my data. But here is patient number 1. She came to see me in clinic. She's an 85-year-old. She has heart disease, status post-cardiac and carotid stents on Plavix. She recently, 6 months ago, had a motor vehicle accident. She had a polytrauma, including a TBI, right leg fractures requiring surgery at the time, multiple rib fractures, and this type 2 odontoid fracture without stenosis, for which she was initially treated non-operatively in a collar at another institution. She's actually recovered quite well from this polytrauma. She lives at home by herself. She's totally self-sufficient with her ADLs. She does use a cane when she comes to clinic. And she comes and she says, this neck pain is killing me. It's 8 out of 10. It's present all the time. And she also says, I've been told I have to live with this collar forever. I would rather die than live with this collar. So what should we do? Yeah, we've been talking about comorbidities. She's old, she's frail. This is the 11-point frailty index, and we'll talk about some of the other frailty indices. Who would operate? Okay, and who would not operate? Okay, a little bit more in favor of operating. Case 2, here's a 90-year-old retired Stanford sleep physician. He's got heart disease, pacemaker, AFib, he's on Eliquis and digoxin, renal insufficiency. He was in Hawaii visiting family 5 weeks ago. He fell and he suffered this non-displaced posterior C1 arch fracture, a concomitant type 2 C2 fracture. He's intact. Before his injury, he was using a cane. Now he's using a walker to get around. And he says his neck pain's like 2 out of 10. It's not really bothering him. He's wearing the collar in your office. And he's had a pretty rough past couple of years. He was actually hospitalized for 2 months this past year for cardiac issues, complications of his heart disease. So once again, what do we do? This acute C1 and C2 fracture. He's 90. He's got a lot of comorbidities. His frailty is even higher. Who would operate? Okay. Who would not operate? Great. Okay, wonderful. And for case 3, I think this one's going to be interesting. So 96-year-old male, this is a consult from the ICU. He is in the ICU. He's got multiple comorbidities, chronic AFib on Eliquis. He's had a fracture that was treated with cervical fusion in Iran in 2015. He's anemic, recurrent pleural effusions. He's had multiple falls, including a lumbar fracture treated non-operatively. Now he's in your ICU after another fall. He's got new rib fractures, a left pleural effusion, and this what we would call an unstable C5-6 fracture. He's got fish mouthing, he's got posterior element fractures, lots of stir signal abnormality. He's intact in his collar. What would people do for this one? Who wants to operate? Okay, who wants not to operate? Great, okay. So the data says that these fractures don't heal very well, especially in these older patients. But we also have an obligation as physicians to first do no harm. And we know that we can do a lot of harm in these 96-year-old frail patients when we're considering treating these unstable spine fractures. So we all know there's an increasing rate of cervical fractures in our increasingly older population. Here's data from the NIS, which is a commercial and non-commercial database on the left. On the right, we have Medicare data. We can see that there's been almost a doubling of cervical fractures after low-impact falls in our increasingly older population. And the reason why I present this relative to hip fractures, I know we've got a bunch of orthopedic surgeons in the room. I'm a neurosurgeon, but I realize that there's been a lot of focus nationally on the morbidity and mortality associated with hip fractures in the elderly. And we know that for many patients, this can be the beginning of the end. And so viewing what's going on with these cervical fractures, even without cervical spinal cord injury in light of this, I think is really important. So while cervical fractures with and without spinal cord injury have been continuing to rise, there's actually been a small decrease in hip fractures. And when we look at our Medicare data over a course of 5 years, we've got over 65,000 admissions for cervical fractures without spinal cord injury. A small fraction of these do have spinal cord injury, and this is in comparison to a little bit over 1 million admissions for hip fractures after low impact falls. So who are these patients? In the NIS data set, these are mostly females. A good majority of these patients have Medicare. Most are treated at teaching hospitals, and falls are the leading mechanism of injury. About 8% of these patients have concomitant spinal cord injuries. The most commonly injured level is C2 in patients that don't have a spinal cord injury, and C1 to 4 in those that do have a spinal cord injury. And overall, about 15% of these patients are undergoing surgery. So an important point is that elderly patients with cervical fractures with or without SCI have very poor outcomes. Across all patients, there's an 11% in-hospital mortality rate. This goes up to nearly 30% for patients who have a spinal cord injury, and only 19% of these patients discharge home, with older age and spinal cord injury non-surprisingly being associated with worse outcomes. And if we compare these to hip fractures, because we know that hip fractures are the beginning of the end, this is from Medicare data on the left. The dashed green line on the top is survival curves after hip fractures. The dashed red line is cervical fractures without a spinal cord injury, so worse than hip fractures. And the blue line is cervical fractures with spinal cord injury, so obviously much worse. And looking at the data, its 1-year mortality rate for cervical fractures without a spinal cord injury is nearly 25%. It's over 41% in patients with spinal cord injury. We've been talking about frailty today. Dr. Failings, your point about adding the MFI-5 is a wonderful one for our study, and I wish you had reviewed our paper before we submitted it. But as we all know, frailty is not just a matter of age, it's also a measure of the degree of physiological reserve. So we've got MFI-5. There's a few simple points here. I graded these patients retrospectively. I didn't grade them in clinic, but I graded them on the 11-point Canadian Health Study. And then, of course, we're all familiar with Charlson and Elixhauser comorbidity scores. We see that frailty is associated with worse outcomes in elderly cervical fractures. The MFI-5 is an independent predictor of mortality for octogenarians with type 2 fractures, independent of operative or non-operative intervention. We see that increasing frailty is non-surprisingly associated with higher adverse events and in-hospital mortality for cervical SCI. And then if we look at just elective spinal surgery, patients with higher frailty indices do worse. Their complication rates are higher, including a 37 times higher complication rate in elective ACDF if you're in the very frail category with the 8 frailty index. So then the question is, we have some of these patients that I presented to you. Can we optimize their frailty pre- and post-operatively? Physical therapy to improve their nutritional status, bone optimizing medication, nutrition, strict medication management. We can. Question is, does this really impact their outcome and make a difference? And I don't think that we have great data at this point in the literature from the different types of studies that we've been doing in order to say whether or not we are meaningfully impacting prospectively patients by doing this. Karen did a great job presenting some of our work on unstable cervical spine fractures, main limitation being that these were ICD-10 codes where surgeons had put in unstable spine fracture. That being said, we obviously don't have fracture morphology, and that's a really big point. And I think the main issue here is that we are seeing better survival curves in our operative patients, but there's clearly a selection bias for who we're operating on that we're not adequately getting from these large database studies. This was another retrospective multi-registry study from Sweden, which actually showed that patients who were treated operatively for C2 fractures, elderly patients, did better. Once again, we've got the selection bias issue. So that gets us back to our cases. Patient number 1, who had more than 6 months of a non-healing type 2 fracture. I did operate on her. She did surprisingly well. She left the hospital at 36 hours. She went back home where she was living independently. She came out of her collar at 6 weeks, and she did very, very well. The second one, I think there was the majority were not going to operate on him. I did not. So I watched him in a collar, did a bone stimulator as well. He came back multiple scans at various times in clinic and in the ED for various admissions. He started to have some healing, but never complete healing across his fractures. He remained neurologically intact, and a year and a half after the first time I met him, at the age of 91, he ended up being admitted to the ICU in cardiac volume overload, sepsis, and family withdrew care. And then the last one was this unstable fracture, which was the most surprising one to me. I did see some hands for operating on this. Once again, this was a 96-year-old. You can see the CT scan, so we had long conversations with the family. We elected to treat him non-operatively in a collar. He came back to clinic, and on his repeat imaging, you can see on the right, he actually improved his alignment and started healing his fracture. He remained neurologically intact, and he's now more than 2 years out from his injury at the age of 98 and traveled back to Iran to be with his family. We did do a collar, some Prolia, and a bone stimulator. So in conclusion, traumatic cervical fractures after low-impact falls are an increasingly important and common issue in our aging population. These are associated with very high mortality and morbidity, and I think we do need to start looking at these issues similar to how the orthopedic surgeons have looked at hip fractures. Frailty is associated with worse outcomes, but it's unclear whether prospectively optimizing frailty makes a difference in some of these patients. And for many high-risk, frail, elderly patients, it's still unclear whether they'll benefit from spine surgery. And we really do have to take each patient and individually weigh the risks and benefits as a surgeon to do the best thing that's right for them. So thank you very much for this opportunity.
Question sort of for the whole group. You brought up the paradigm of the hip fracture, the anticipated mortality in the first year following the event. We understand it as a sentinel event in someone's healthcare. And then there's sort of a parallel potentially to be drawn with the age population and cervical fractures. But there's also a difference. You know, our colleagues have been spending decades trying to figure out how to quickly and effectively fix that fracture. In our hospital, most of them are done under spinal anesthesia. The surgeon is rolling the patient to the PACU by the time we're scrubbing after prepping and draping for a cervical procedure. So the physiologic stress of fixing that hip fracture and what we are talking about doing for a cervical spine fracture are widely different. So I'm just sort of interested in what people's thoughts are about how apt is the comparison to the hip fracture patient versus the group that you guys have all been talking about.
Well, I think as one of the few non-ortho surgeons here, I probably am the least able to talk about the comparison with hip fractures, as I've never, fixed a hip. I think that I'm obviously, junior in my practice, but I presented a couple of those cases, especially the third one, because it has made me a lot more conservative in treatment of these fractures in the elderly. Because when I saw that initial C5-6 fish mouth widening, 3-column, multiple posterior spinal fractures, I assumed, I was taught, this is unstable, this needs to be treated. And I thought, for sure nothing good's going to happen. This guy's 96, he's in this collar, he's going to get intubated for some procedure, he's going to have complications as a result of it. And it actually healed very nicely on its own. So I think, personally in my practice, I have led more towards being more conservative. I love the conversation about frailty, but I think one of the other points was, I don't know if you noticed, but the frailty scores were almost exactly the same for all three of my patients. And when I told you the stories of them, there was so much more to their stories. Cardiac disease that has been very stable, even though they're on a blood thinner for the last 5 years, is a different story than the guy who's been hospitalized for 2 months for cardiac failure recently. So even these frailty measures, they're obviously better than just age, but I don't think they're adequately capturing everything about our patients. So, when you do look at the data, though, the mortality rates are really high, whether we operate or not. So, we do need to think about treating these patients if we think that the complications are going to be really bad. And when I do look at the literature, it does push me a little bit more towards thinking, yeah, maybe we should be considering operating on these patients. But then in my own practice, I've sort of had a different experience, and I think every patient's story is more complex even than the most sophisticated frailty index. And I'm sure, all the practicing surgeons here feel that way.
Yeah, I'll chime in. I think, John, your point is very well taken, that these are different interventions, and the implications of both surgical and non-surgical management in the two populations are very different, right? In terms of additional morbidity that it comes along with non-operative management. But I do think that there is a common thread, which is the host. And I think you described it very well, that there's nuance there. But if you look at it at population level and away from our individual practices, I think there are similarities that we can carry forward. I think we heard a really good summary of the physiologic and bone-specific issues at play, and it's the same in both groups. The fundamental difference as I sit back is that there are just so many more hip fractures every year, right, than there are cervical fractures in this population. There are extrinsic motivations that have also led a lot of centers to come up with really at least consistent hip fracture protocols, right? These are publicly reported outcomes. And so that also has incentivized the treatment of consistent treatment algorithms or protocols, and we don't have that. So I think what we see right now is a lot of fragmentation, right? We all do it a little different. Northeast Ohio, West Virginia, they all have different ways of managing these fractures. I would love, if we have time, if there are any of our colleagues from overseas, from outside of the U.S., who maybe have a little bit more of a systematic way of addressing this population level. I'd love to hear from them, if not right now, during the meeting.
Well, some of the data, though, are actually really encouraging. What was reflected is spine surgeons tend to be a bit more thoughtful and reserved about surgical intervention in this group. 98 to 99% of hip fractures that roll in the door get fixed. It's rare that the circumstance precludes surgery, but yet the data are still the data. I mean, 20% of them expire. So, I think we're being thoughtful. It's very nuanced and complicated, but it sounds like at least our instincts are leading us in the right direction. We just need to be more scientific about it, I suppose.
We'll take one more question.
Yeah, thank you. Steve Ludwig from Maryland Shock Trauma. My question is for Tim. I know you focused on a lot of the inappropriate patients that were subsequently transferred down to Metro. We actually have the sort of the reverse problem. With the economics that's going on, with the nursing shortages, with our OR resource issues that are not uncommon for everybody in this room, we're often challenged with that trauma patient, elderly, that's sitting at an outside hospital and is waiting. And they're waiting, and we're trying to get them over, but yet they go from a certain magnitude of trauma and physiologic distress to a much more burdensome level of management. And my question to you is, do you have a protocol where you guys say, we can't, you got to get this patient to another hospital, we can accept them, but there's a liability associated with that, your name is associated with that patient? Do you have any experience with that?
Yeah, I don't. When I'm on call, I'm always shocked at what I get called for, and even more shocked what I don't get called about. But oftentimes I'm on the phone talking to treating physicians, at outside institutions, and I don't. At Metro, at my institution, we tend to find a bed for them, whether it be, I don't tell an outside treating physician to send a patient elsewhere. We just don't send patients out. I think, we're a trauma hospital. We're in the middle of huge, wonderful healthcare institution, and, we're considered a regional center. So I haven't had the issue of sending a patient to another hospital. I think that would involve tremendous liability, like you said. And it might be hospital day 3, okay, but we're going to get that patient to our center and treat them for there. But for this, a bunch of them, we were the 4th hospital that the patient got to at that time.